Margaret, or I don't Maggie Watkins. And so we're going to take a little bit of a change and talk a little bit about flu. I know that there's a lot of change happening with COVID in regards to Moderna and J&J and mixing. I think that will be a great topic for a future echo because ACIP is meeting as we speak. So we certainly will answer any questions that we have about that, but thought we should talk about the importance of flu because we are seeing we're going to have flu season come here very shortly. So thank you all for joining us. And we'll just kind of go over influenza as an etiologic agent and talk about signs and symptoms, and then talk about treatment efforts, as well as then we'll talk about kind of what prior influenza seasons have looked like in regards to some of the epidemiology of it, and then talk a little bit about vaccine recommendations. Neither of us have any financial disclosures. So I know we've been talking a lot about COVID or SARS-CoV-2 the past year, 20 months really, and then specifically on this echo as well. But we have other viruses that are out there, and we're approaching our influenza season. So here's just kind of an overview as a reminder of the influenza viruses. So they can be classified into types A through D. A and B tend to cause those seasonal epidemics. Type A then gets further divided into H's and N's, and B is divided into lineages. So I think probably H1N1 is probably the most recent H and N we frequently have heard talk about. Prior to the pandemic that we're in, that was the last concerning pandemic epidemic we had. And through the influenza, we can see this circulation and change through antigenic drift, which is those small changes in type A and B viruses. That's why it's important that we get an annual influenza vaccine. And then we have the antigen shift, which is that recombination of more than one type A influenza virus. So how does the flu virus transmit? And so we definitely know that it's spread through person to person, and mostly those respiratory droplets when you cough, sneeze, talk, sing. So a lot of things we've been hearing also with COVID-19, specifically close contact within 6 feet, possibly by touching our nose, mouth, eyes, or maybe coming into contact with contaminated surfaces, but certainly not likely to be transmitted through food. So here you can see the incubation period, 1 to 4 days. Usually our symptoms will come on within 2 days. And then similarly, somewhat with COVID, but obviously different times, you know, they can be contagious. People can be contagious before they start to have symptoms, and then up to 7 days after symptoms. And then you can see there the R0. We've all heard a lot about R0s, probably more than ever past in our life when we're talking about our transmissibility. So when we talk about influenza, what are the signs and symptoms? Last year, we had a pretty mild influenza season, which Maggie will talk more about that. But, you know, when we're talking about clinical characteristics of influenza, fever, cough, sore throat, runny nose, being tired, those myalgias or muscle aches, headache. And then in children who I primarily care for, we can see more vomiting and diarrhea. We can see complications from influenza, similar to complications we can see from any virus, but certainly with influenza, more severe disease, pneumonia, respiratory failure, ARDS, that acute respiratory disease, sepsis, cardiac injury, multi-organ failure, worsening of underlying chronic medical conditions. So individuals, we have a high amount of COPD in our state. So is this worsening of that? And then secondary bacterial infections, particularly staph organisms, MRSA, having a complication of influenza. So I think it's important for us to note early in this pandemic, you know, we didn't know how much co-infection would be possible, but we do know that you can be co-infected with SARS-CoV-2 or COVID-19, and then also get other viruses, influenza being one. So who's at high risk? So we know that there's certain individuals that are at higher risk populations. So really with flu, those children who are younger than 2 years of age, and then individuals in the later decades of life, so 65 and above, racial and ethnic minorities, pregnant women, and then adults with all these different chronic medical conditions, as you can see here. So an underlying lung condition, but also heart disease, liver disease, neurologic conditions, people who experience obesity, and then if you're immunocompromised, either due to a disease or to medications. And this is important because when we talk about antiviral treatments that we have available for influenza, there are different priority groups for those treatments, individuals who have that are hospitalized, or people who have severe disease as well. And so we want to make sure that we're looking at these different priority groups to then ensure that if they do contract or have symptoms consistent with influenza, that we're providing the antiviral treatments we have available. We're going to talk about vaccination. So hopefully these individuals have been vaccinated, but also there are antiviral treatments as well. So what are those antiviral options? So for outpatients that have acute uncomplicated influenza, the oral oseltamivir, so Tamiflu, but then also inhaled zanamivir. There's also IV formulations, IV perimivir, and then oral baloxavir for treatment. And then the CDC, it's important to note that they don't recommend that you wait for laboratory results to initiate empiric treatment for those priority groups that we saw on the last slide. We believe that the clinical benefit happens greatest when you started as close to illness onset as possible, so ideally within 48 hours. The oral oseltamivir is the preferred treatment for pregnant women and for individuals or outpatients with complications of progressive disease. And then for hospitalized patients who have suspected or confirmed influenza, want to start that with oral or something that can be given enterically administered is recommended as soon as possible. And then there is a link that I can drop into the chat later in regards to the guidelines for treatment and prophylaxis and what populations we should provide prophylaxis. So now I'm going to turn it over to Margaret Watkins, who has been so kind to join us and works in the Office of Epi and Prevention Services and is our influenza surveillance lead, and just really appreciate you being here to kind of talk about influenza surveillance and the role that we can play, and then also share some epidemiologic.
Thank you, Dr. Costello. I think you pressed mute right before you finished, but if you want to just move through the slides for me, you able to do that? Okay, so I'm just going to talk about some of the importance of influenza surveillance and really how it's done here in the state of West Virginia. So the CDC identifies many reasons why influenza surveillance is important. Of course, it identifies any new or novel influenza viruses that may be circulating. It helps in vaccine component selection and also refining the annual vaccine, in addition to the antiviral recommendations and treatment decisions for healthcare providers. It also identifies high-risk persons who Dr. Costello already mentioned those, and any maybe new high-risk populations that we want to start to focus on. And it also determines the effectiveness of prevention strategies that we utilize both in the state and nationwide. Next slide. So the required reporting here in the state of West Virginia, first of all, we have our clinical laboratories, which is the hospital labs or reference labs. They are supposed to report to the State Health Department, to the Division of Infectious Disease Epidemiology, their positive influenza tests and the total number of influenza tests they run on a weekly basis, and they just send those in aggregate counts. So we don't collect any PII. We just want to know how many flu tests they're running and how many positive flu results they receive. And then also that gets reported right to the state. And then at the local health department level, we have the reporting of influenza-associated pediatric deaths. We ask that those be reported within 1 week to the local health department. And then any novel influenza strain that's found, we want that reported immediately to the local health department, and also any outbreaks, which I'm going to go over the definition for that as well. Those get reported immediately as to the local health department. Next slide. So this is on the right, you'll see the image. That's our paper laboratory reporting form that we've always utilized in the past. Again, this is what I mentioned for the hospital and reference labs to report the number of tests that they're running and the number of positives they receive. All of the flu surveillance is done by MMWR week, so it's done on a weekly basis, everything from Sunday to Saturday. And we ask that those are reported the following week, hopefully by Tuesday of the following week. I know sometimes holidays can run into issues with that. And some reporters, some hospitals are linked up to ELR, electronic lab reporting, especially post-COVID, when those results still have to be reported electronically to the state health department. But regardless of if the reporter or the hospital is sending electronic lab reports, they still need to send these weekly aggregate counts, because there's really no way for us to deduplicate any of that if they're contributing to both. And the state has recently transitioned from Microsoft to Google. So now we have an electronic report form available through Google Forms, where it's much easier and quicker for everyone to enter the data into an electronic version of this form. And then it's much easier for us to analyze it on our end and saves everyone a little time. There is an alternative to reporting to the state health department. We do have 4 or 5 providers across the state, all hospitals, I believe, that report directly to the CDC, and that's mostly through the National Respiratory and Enteric Virus Surveillance System. Next slide. So when I talk about reporting influenza lab results, I'm not talking about serology and the antigenic labs. We're only talking about any of those that have like molecular detection, the PCRs, the immunoassays, and any of the cultures. I'm not going to go through this whole table with you. I mean, it's just kind of there for your reference. But that I just wanted to highlight that any provider doing those rapid antigen tests, those do not need to be reported directly to us. If they do have a positive, of course, we want those specimens to be sent to the state lab here in South Charleston, and they can do further testing on it, typing, subtyping, and lineage testing. But really, when we talk about, I call them confirmatory tests. A lot of times I get questions about that when they say, well, which ones do I need to report? It's those confirmatory flu tests, not serology and not any of the rapid antigen tests. Next slide. So besides the lab reporters, we also have providers that can report, and it's an optional, we call them Sentinel providers, and they can participate in influenza surveillance during the flu season by reporting directly to the CDC through ILINet. And ILINet is the system that does those flu view reports. If any of you are familiar with those, they come out every Friday. And it's it's a great surveillance system and kind of shows what's happening nationwide. So for a provider to become a Sentinel provider, basically they just need to be a primary healthcare provider of any specialty. We have OBGYNs, we have pediatricians, anyone that's basically seeing patients on an outpatient basis. And they just have to be able to log into ILINet and report the counts every week. Again, it goes from Sunday to Saturday, the MMWR weeks. And we just want to note that it is different than reporting clinical labs reporting, and it also is different from Essence, which is where we get our data from, mostly emergency rooms and more hospital data. So again, the Sentinel provider stream is just for if you're seeing patients on an outpatient basis. We do have some incentives for those that agree to be Sentinel providers. We offer free doses of adult influenza vaccine. They just request how many that they would like. Usually it's based on the number of staff they have at their practice, but you can always justify asking for a little more. And most providers, if staff are insured or they already offer to their staff, they'll use those doses for their patients that are uninsured or underinsured and utilize them that way. Also, our Sentinel providers are able to have free shipping and confirmatory testing done at the state lab at OLS. They're also priority if there's ever any backup or lots of specimens being sent in at once. They're considered priority providers at OLS. And then we also provide weekly reports on state and regional flu activity that, again, we try to send out every Friday, and they're on the listserv for that as well. Next slide. So ILI, we just recently had a case definition change of what is considered influenza-like illness. So ILINet now considers anyone with ILI to have fever. That's the first first priority is having a fever, and they consider that anything over 100. And then the second would be cough and or sore throat. So those are the two criteria for someone to have ILI. They have to have the fever, and then cough and or sore throat. Previously, there was a third criteria that said no other known etiology, but now ILINet and ILI in general, they want it to be more of a broader respiratory surveillance system. So we are going to include anyone that has that fever and cough and or sore throat. So essentially, you could have a patient that tests positive for RSV, they could test positive for COVID, but they would still meet the criteria for a patient that is ILI, and they would still need to be reported in ILINet or Essence or any of the other places they might be reporting ILI. And for respiratory outbreaks, I mentioned that earlier, those are supposed to be reported to the local health department immediately. We use the McGreer criteria for ILI, which is fever and at least 3 of the following sub-criteria. So it's a little more, so you still always have that fever, but then any of the sub-criteria there listed: chills, headache or eye pain, myalgia, malaise, sore throat, or increased dry cough. And there's more information there on the link at the bottom about what meets the criteria for an outbreak and what doesn't. But if there's any facility, I mean, if most of you are providers, and you could also have outbreaks occur at your office, among staff. So if you're ever just not sure, you can always call the local health department, or they could even, you can call us here at the state, and we can determine whether or not it meets the outbreak case definition or not. Next slide. So as Dr. Costello already mentioned, over to the right, you can see where we were our last flu surveillance season. We didn't have much of a flu season at all. It was very low or limited circulation. You can see all the humps in the years prior. I think flu tends to go, it kind of has what we call like a bad season every other year. So, you see the in 2018, and then again over there in 2020, you see you have higher peaks there, and then the lower peak in the 2018 to 2019 season. Unfortunately, it's great that we had a low influenza season, but when it comes to sharing data, that's not what epidemiologists like, because it makes it more difficult to predict what's going to happen this year. So there are predictions out there. It's that it may be a very hard influenza season, a bad influenza season, but it's so difficult to tell based on the limited data that we had available from last year. Next slide. So there's some different thoughts about why we had record-breaking low numbers in the previous season, mostly probably attributed to the COVID-19 mitigation strategies, more people social distancing, staying home, wearing masks, using lots of hand sanitizer. We've also had testing rates increase based on previous years, and the CDC also reported a record number of vaccine distribution in that 2020 to 2021 season. Remember, it was before the COVID vaccine was available, and there was a lot of push to prevent a dual pandemic, with flu and COVID. So we did have a lot of vaccines that were distributed. So we're hoping that testing rates remain high. Unfortunately, the lack of community exposure and natural immunity from last season may contribute to a bad flu season this year, but where, of course, we'll find out, I guess, as we go. There also is a concern for possible lowered vaccine confidence, and I think maybe that could be due to some of the vaccine confidence around COVID-19, but of course we're hoping that vaccine rates remain high this year. We're pushing our flu before boo, so that everyone can get their COVID vaccine before Halloween, which is already coming up next week. Of course, anyone can get their flu vaccine after Halloween, through the months of November, December, all the way into the new year. But we want people to try to be vaccinated before Halloween whenever possible. And then I put the outbreaks that were reported to the state health department listed there at the bottom. You see from year to year in 2019, 62.5% of the respiratory outbreaks we had opened were due to influenza. In 2020, it was 76.5%. And then in 2021, so back when I prepared the slides, there was only 2 of 5 respiratory outbreaks were determined to be influenza, which is 40%. And I know we haven't had any other ones open since then. So if anything, only that denominator has gotten bigger and the percentage has gotten smaller. So we definitely saw that, that sharp decrease in 2021. Next slide. And that's it for surveillance. I'm going to stick around if there's any questions, but otherwise, Dr. Costello, go ahead.
Well, thank you so much, Maggie. Appreciate you being here and sticking around for any questions. We will briefly talk just about some of those mitigation strategies, and then certainly want to open up for time for questions. So I think we're all talking a lot about vaccine confidence in a variety of ways. I do personally think, I'll just speak from my own experience. This is the first year, I think, since I was even before a medical student, I had to go somewhere else than my health institution to get my flu vaccine because they're not offering it until November. Last year, we had a much earlier offering of influenza vaccines. And so vaccination is still our best protection for influenza. Obviously, we want to get people vaccinated ahead of time. I'm a pediatrician. I always like to say flu before boo. So the ideal time is to get your flu shot before the end of October, and it takes 2 weeks to build that immunity. We've seen different strategies as people are trying to increase COVID-19 vaccinations. They're delaying offering influenza vaccines. So as Maggie said, although last season was encouraging in that it was a lower influenza season, I think many of us are more concerned that this year could be more of a twindemic, or having increased influenza on top of increased COVID cases, although we're seeing our COVID cases kind of plateau right now. We're always following variants and concerned about the potential next surge that we might see with that. So when we talk about influenza vaccination, this is how many you can see in regards to supply. So 100, close to 200 million. All vaccines produced for this flu season will be quadrivalent. Most 87% are thimerosal free or thimerosal reduced vaccine. Only multi-dose vial presentations of flu vaccine will contain that thimerosal, and about 18% of flu vaccines are egg-free. And so when we talk about the egg-based vaccines, one of the recommended strains of influenza A is different for egg-based and for cell-based influenza vaccines this season. And so here you can see the different types of egg-based vaccines that contain the following strains. And then based upon the cell-based and recombinant vaccines that are egg-free. So this will kind of all depend upon what your clinic, what your hospital, what you have access to receiving. So you can see here as well as to what egg-free vaccines contain those strains. And so when we talk about the flu vaccine this season, the standard inactivated injectable influenza vaccine, there is a high dose vaccine for persons 65 and older, as well as an adjuvant high dose vaccine for persons 65 and older. We have those cell-based injectable vaccines where the virus is not grown in eggs, and the recombinant vaccine virus also egg-free. There is recommendations. I think this is something that has always changed in regards to, is the nasal spray effective? So that's the live attenuated influenza vaccine administered by nasal spray that is available this year. And recommended for certain groups, or available for certain groups. It's not recommended in some groups. And then I think it's really important to highlight, because this has been an ongoing question, the flu vaccine can be co-administered with other vaccines. So that includes the COVID-19 doses and boosters. It's just typical that you should give them at different anatomical sites, or at least if you're giving them in the same extremity, to have at least 1 inch difference between the two. So when we talk about state, and I want to say thank you to Jeff Nacuzzi and the Division of Immunization Services and the DHHR for much of the content of these slides, but the DHHR, Bureau for Public Health, does provide free flu vaccines for children who are under age 18 that are eligible for the Vaccine for Children program and the Children's Health Insurance program. Here you can see, what the VFC eligibility would be. They do offer free vaccines for adults at free clinics and then community health centers. So beginning in mid-October, they'll be able to offer flu vaccines. We've also seen health departments as well offer flu vaccines as well. Have seen many offer flu vaccines and COVID vaccines, and then flu vaccines are also available at other locations. Perhaps you carry them in your clinic, or available at pharmacies as well. So just to touch briefly on other prevention strategies, Maggie spoke a little bit about, could these measures that we were deploying for COVID-19 have played a role in how influenza then spread. So it's important that we continue to remember these. I think as we progress through the pandemic, we've forgot about some of these, but important to cover those coughs and sneezes, to stay distant, stay home if you're sick, hand hygiene, and then also PPE. I'm working in the hospital right now. That's why I still have my mask on as I'm presenting to you. So when we're talking about considerations, I think we hear this a lot. Is it COVID? Is it influenza? Could it be both? So we know that co-administration can certainly happen. But we've continued to see and recommend masks for patients and visitors throughout the healthcare facility, and then also continue kind of the use of respiratory triage or waiting area for those that allow distancing between patients. So still having separation of patients in waiting rooms to try to, again, promote that physical distance between individuals to try to help reduce the spread. Hand hygiene is incredibly important. So it remains one of the most effective. I think early in the pandemic, we saw a lot more people kind of commit to hand hygiene, but it's really important that we continue to do that. So at least 20 seconds of soap and water or those alcohol-based hand rubs, and then encourage and enforce hand hygiene programs at your institutions or your clinics. So to have that program that your organization can follow, and then also, to perform audits to see how well your institution or your group does. And then again, just respiratory etiquette. But again, if these images are available through CDC, so you can certainly hang these up in your clinics, but making sure that we continue to communicate about how to cover coughs and sneezes. Hopefully many people are still wearing masks, but if they're not, making sure that you use a tissue and throw that away, making sure you're not coughing into your hands, but into your sleeve, your elbow. And then I think it's important that we continue to wear PPE. And so making sure you're wearing that full PPE if you're caring for these individual, and then direct contact of positive influenza can dictate the need for masks and gloves. I work in the inpatient setting, so I've still been wearing my N95 and my goggles just because I think it's I would prefer to take a little bit of the extra protection as we're moving further into viral season. And then again, kind of maintaining that at least 6 feet apart. So encouraging that distancing, including in your waiting areas, making sure that we're cleaning those common areas as well. And then if we can, cohort patients, particularly cohorting those who have confirmed illness to help further prevent the spread. So just to kind of close up here, and then we'll welcome any questions that you may have for the remaining time we have together. Really consider testing patients who have respiratory symptoms. If you have a full respiratory panel, I've been seeing, we have a multiplex biofire that can be offered, but then there's also the combination flu, RSV, and COVID, so that we can have a better understanding of what perhaps is the person experiencing. Again, Maggie did a great job talking about surveillance, but it's really important for identifying novel influenza, and then it also helps us for future influenza season and helping us adapt the influenza vaccine to make sure that we are providing protection to those most common strains that we're seeing out there. So the flu vaccine is recommended for anyone 6 months or older without contraindications. So for those 6 months of age up until age 9, they need to have 2 shots as their first. So once they've had a 2 shot as their first, then they can go to have a yearly vaccine. But that's really important in regards to particularly the 6 months old, if they're getting their first flu vaccine, to make sure they get their second dose a month later. We can co-administer the influenza vaccine with the COVID-19 vaccine, as well as other vaccines. Again, little shout out for the flu before boo. So trying to get people vaccinated as early as possible to help prevent that twindemic. And then it's really important that we follow those other infection control practices to try to help mitigate the spread. And by educating our staffs and one another is really important. And if we can perform an audit just to kind of see how well we're doing. So I will stop there and open up to any questions, and appreciate Maggie sticking around to help answer questions too.
Thank you so very much. That was excellent. I appreciate both of you and your knowledge today and sharing that with us. I see one question in here, but please feel free to unmute or raise your hand or chat in a question for us. Can the presenters comment on the efficiency of high dose versus standard quadrivalent dose vaccine? Thank you.
I think certainly for the older population, the higher dose, you know, I would have to look at specifically the efficacy numbers. I've been looking at all the ACIP data and FDA data on Moderna and J&J and everything, so I don't want to misspeak for the flu vaccine. But I think in regards to that older population, certainly important for the higher dose in regards to mounting an immune response. But I could certainly try to find the specific numbers for you, Dr. Rexroad, but I don't know if anybody else on the line has them. But sorry, I don't have those.
I was just curious because we've gotten some comments, and we have some older people who refuse the higher dose because they claim that that gives them more side effects than the regular dose. And I mean, I'm happy just for them to have one, but you know, I guess I was looking for a little more ammunition to try to persuade them that maybe they really do need the higher dose.
Yeah, I mean, I think it's a good point, right? I mean, that's what we're going to see what ACIP says. I mean, the Moderna booster dose is projected to be half of what the dose will be. So one could argue, you know, as you have the higher dose, does that then contribute to more symptoms? But I think it's in regards to, you know, ensuring people have as robust of an immune response, those symptoms that they may have may be better than actually coming down with the flu and, you know, then leading to hospitalization. But I think it's challenging because we're seeing a lot of questions, and Maggie talked about this, about vaccine confidence surrounding the COVID vaccine. I certainly think we're seeing that spill into other vaccines as well. And so I think that's important. So thanks, Maggie, for dropping all of that into the chat.
Yeah, I put the link in there, but I just copied and pasted the part about 2 different studies about the high dose vaccine.
Thank you so much for providing that, Maggie. Appreciate it. We'll include that in the recap as well with that link for everyone to utilize. Another, were there any cases of positive influenza with COVID-19 last season in pediatrics or adult?
Not that I know of. I'd have to look back and see. But again, we had such a low number of positive flu patients. I don't believe there was any co-infection that way. We had co-infection COVID-19 and other respiratory viruses, but not flu that I can recall. I'll have to double check though.
Yeah, and I think, you know, just kind of chiming onto that, again, it was such a low season last year. I mean, we know that co-infection is possible. So I think as we see the Delta, you know, variant, I mean, obviously there's so many more things into play this flu season. We have a highly effective COVID-19 vaccine, although we don't see uptake, particularly in our state, as high as we would like it to be. We're seeing some places not be as aggressive with influenza vaccines, so waiting, you know, longer to give the COVID-19 vaccine first, and then even though they can be kosher, I think it's like a logistical challenge, and so and we've seen a reduction strategies. So I think time will tell in regards to what co-infection rates may look like this season. I'm sure nationally there were, you know, some cases of that because we've certainly seen that. But again, I think we just saw so low numbers that we weren't seeing it at least at the same time.
And it does, it makes me want to mention the testing recommendations. You know, the CDC recommends at minimum to test anyone that's symptomatic during flu season, to test them for COVID, flu, those 2 at minimum. Dr. Costello also mentioned like a 4-point where it does COVID, flu A, flu B, and RSV. But anytime you have the capability, the capacity, the funds to do a full respiratory panel, that's always going to be preferred. It can be quite expensive, but a lot of labs kind of do where if you have a specimen from a symptomatic patient, you run it on the COVID and flu first. And if it's negative for that, then you can just kind of go down the line. And eventually, if it's testing negative for everything else, then you can do the full respiratory panel, because it's great for surveillance purposes. I know the CDC is collecting a lot of data with comorbidity with COVID-19, but it's also important for providers to know exactly what their patient's testing positive for, so they know what kind of treatments to recommend.
Thank you so much, both of you, for those answers. Does anybody else have any questions or further comments? And thank you for providing that link as well, Dr. Costello. We'll provide that in the recap.
Yeah, I was just trying to drop in some of the links that were within our presentation, but feel free to, you can kind of pull those out as well for the recap as well.
Perfect. Thank you so much.
And I would just be interested, has anyone seen, I had one case of flu A. It was in it actually was co-infected with RSV, but it was I'm blanking on the name. It was less than 5, I think maybe even less than 3 years old, but did require hospitalization. But I saw that a couple weeks ago. I'm on service right now. We're still seeing a great deal of RSV, but haven't seen any other influenza. But just anecdotally, what people have seen, or if they're starting to see flu in their clinics.
I think we've had one in Pendleton County.
Yeah, I think that's what we're all, it's been great. And if we could still have a small, like a low flu season like we did last year, but I think a lot of, we saw more strain with this most recent Delta surge than we ever experienced in West Virginia. And I think at least me, and I think many people in public health are super concerned that if you would see, ongoing case numbers, even though we're plateauing with COVID-19 that then require hospitalization, you add in flu, we're going to really have a challenge on our hands in regards to hospital capacity and being able to care for patients.
We've seen one adult flu and one adult RSV so far here in Cecil Mill.
I think all the more reason to, and thanks for sharing that, and Maggie chimed in that we've had minimal flu A reported in the last 2 weeks, no flu B yet. But I think it's important when we're particularly emphasizing the importance of vaccination. Maybe people are going to be coming to get their COVID booster, reminding them that it's also important to get vaccinated against other preventable, other diseases that we have vaccines for, like flu. I think it's going to be important. There's certainly some communication out there, but it seems as Maggie said, last year at this time, we didn't have a COVID-19 vaccine. And so now we're really seeing ongoing more discussion about the COVID-19 vaccine and trying to encourage vaccine uptake and improve confidence for COVID-19 vaccine. But it's important to also encourage vaccination and other, because last year we did see higher numbers than we had previously in flu vaccine rates. But I think that adds to concern. If we see less vaccine rates, less other mitigation strategies, it's potentially setting us up for a worse flu season.
Thank you so much. This is a reminder, I need to go get my flu shot. Has everyone received theirs yet? You go do it before next week, right? Flu before boo. Anybody else have any questions or anything before our final announcements and our poll?
Dr. Rexroad, did you have anything? Obviously, I always appreciate, Dr. Rexroad, also a health officer.
No, I think we're just trying to get the word out. I mean, our local health department administrator was on local TV last week encouraging all the vaccines, but we're doing what we can.
Thank you. Any final remarks, Dr. Costello or Maggie?
Nope, I'll just say while I have the floor to shift, I know we've talked about influenza, and I think that's incredibly important, but for those who care for children, there is anticipation of authorization of a 5 to 11-year-old vaccine, the Pfizer dose. It will be a different dose, a different vial. It has different, Constitution requirements. So the White House just yesterday kind of released how their rollout is planning for those who are interested in, maybe if they care for children, they haven't offered COVID-19 vaccines. Certainly you should sign up to become a vaccine provider for influenza, but if you also want to offer COVID-19 vaccines, you can reach out to, you can go to coronavirus.wv.gov. It has on the provider site a link as well. You can also reach out to the Division of Immunization Services to become enrolled in that program. But I do think we're going to see more and more just conversation of vaccines in the media. But we're certainly waiting for the FDA to give their final review and then see ACIP. Same with Moderna and J&J boosters and mixing. We should know more by this evening of what ACIP decides. But there's going to be a lot of information coming out in regards to COVID-19 as well in the upcoming days and weeks.
Thank you very much. Thank you again. I just have a couple announcements. First, our next session will be November 18th to be determined. So just keep a lookout for that about the topic and presenter. And then I do apologize. I think some people are having difficulty getting online today. I think the link sometimes in the email, I apologize. I think sometimes it just gets glitchy. Please use your calendar invites. And if you don't have those calendar invites, just reach out to me or myself. We can send you that form, fill it out, and then we can make sure you are on the listservs and get those invites, because that's the best way to try to access the meeting. And then lastly, there's the link. Thanks, Peter. I will go ahead and launch the poll.